Hello dears, in this video I will explain the maxillary sinusitis. Chronic rhinosinusitis, CRS, affects around 11% of the population and has a multifactorial etiology, including factors like ciliary dyskinesia, allergy, asthma, bacteria, Staphylococcus aureus, fungi, and anatomical variations, e.g., deviated septum, concha bullosa. CRS is classified into CRS with nasal polyps, CRSwNPs, and without, CRSsNPs, as well as primary or secondary, and local or diffuse disease. Nasal polyps, benign swellings of the sinus mucosa, are characterized by an edematous stroma with inflammatory cells and eosinophils. Clinically, patients with CRSwNPs present with nasal obstruction, watery rhinorrhea, postnasal drip, and hyposmia/anosmia. Polyps are identified as pale, semi-transparent gray masses in the nose, which are mobile and insensitive to palpation. Medical treatment for CRSwNPs includes systemic steroids to reduce polyp size and topical corticosteroid drops and sprays for maintenance. However, polyps often recur after treatment cessation. Biological treatments using monoclonal antibodies are an emerging therapy. For CRSsNPs, in addition to topical treatments, long courses of low-dose antibiotics, macrolides, can be used for patients with normal immunoglobulin E levels. Surgical treatment, such as endoscopic nasal polypectomy and functional endoscopic sinus surgery, FESS, is considered when medical treatments fail. A CT scan is performed preoperatively to assess disease extent and anatomical details. FESS complications include CSF leak and orbital issues, necessitating careful preoperative review of CT scans. Endoscopic polypectomy uses a powered nasal microdebrider, and image guidance may be employed in extended endoscopic procedures for real-time feedback based on preoperative CT or MRI scans. Malignant tumors within the nasal cavity and paranasal sinuses most commonly include squamous cell carcinomas, adenoid cystic carcinomas, and adenocarcinomas. Adenocarcinoma is particularly associated with exposure to hardwood dust in the furniture industry. Adenoid cystic carcinomas originate from minor salivary glands present in the nose. Suspicious signs of tumor invasion into neighboring tissues include diplopia, proptosis, loosening of the teeth, trismus, cranial nerve palsies, and regional lymphadenopathy. Imaging, such as MRI, can reveal the extent of invasion, as seen with left maxillary antral carcinomas involving adjacent structures including the orbit. Management of these malignancies is optimized in a multidisciplinary clinic where ENT surgeons, maxillofacial surgeons, and oncologists collaborate for comprehensive care.